Good morning and thank you very much. So I'll be presenting the parotidectomy by robotic infraclavicular approach. And see for the and as I have to keep my presentation short, so this is the way we actually have classified zones in parotid. Not the superficial lobe and deep lobe. It is three zones because each zone has a different difficulty level which we have to handle as we go on. So one is the tail, three is the superficial part above the the zone one, and two is the deep zone. So this is how we classify. And in the process of this ideal platform, we are in somewhere in 2A or B. So, I'll just show some short videos to make you understand why it is like this. So, this is zone 1. So, it's very simple to raise the flap. We have done it before, but the dissection in this technique, actually, once you expose the tumor, it is a retrograde dissection. The facial nerve, the marginal mandibular nerve is identified, and we go backwards. This is the great auricular nerve. The tumor is dissected, and once the tail of parotid is lifted up, so that's where the tumor is, and this is the digastric muscle, and we go and identify the marginal mandibular nerve. That's a marginal mandibular nerve, and the dissection happens in retrograde manner. So this actually, for as a surgical oncologist and many of us head and neck surgeons, we are familiar with the marginal mandibular nerve anatomy, and it makes it easier for us to trace it backwards and take it to the root and do a complete dissection as we want. I showed you the zone 1. Zone 2 is what I had submitted. I think any of you who have gone through the videos will know what we do here. Again, the same thing, but what happens here is the tumor is located deeper to the facial nerve. So, preserving it by gentle dissection all around the nerve is extremely important. So this is the facial nerve, the cervical branch of the facial nerve. You can see the nerve, stretching over as you go on. I'll show you little later in the video. Yeah, this is the facial nerve stretching across the tumor. This is the tumor which is under it. It is possible to dissect it and preserve the function. And it is easier in robotic because you're seeing from down. So that is for zone 2 and zone 3. This is how in fact zone 3 is the most difficult part because it is in front of the ear and the access is very difficult. Even with retroauricular approach, it's very difficult to do, but I think when we do PRIA approach, it makes it easier because we are seeing from down, and we can go raise our flap as high as possible. So that is the facial nerve which you are seeing here. These are the rootlets of it. This is the upper branch or upper trunk which is going towards the ear. That's a very important branch to preserve. So this is all the 5 branches clearly shown. So now coming from there, can we extend this technique to further tumors? This is one of the things which we have a few cases like this. The parapharyngeal tumors we can address with the same approach. We can that tumor is near the nasopharynx. So when we go up, we can get into that plane without doing a mandibulotomy. It's possible to get into parapharyngeal spaces. That's the hypoglossal nerve which you are seeing. This is the internal jugular vein, the external carotid artery, and that is the tumor. So that tumor is in the parapharyngeal space, which can be approached even by TORS. But with this, we can our lateral aspect of the tumor is dissected, and we are very sure about our lateral anatomy. And part of the tumor, if part of mobilization has to be done from mouth, it is possible to do. In this patient, I think we had done, and we could deliver it from the from the neck incision in toto. So apart from this, of course, neck dissection is possible. Robotic infraclavicular approach really helps in neck dissection as well. This is one of the patients where we have done radical neck dissection along with parotidectomy for a malignancy. It is possible to achieve it with the same incision, no change in the incision. So this is just the data of 11 patients. We have been able to, give, as far as the patient satisfaction, as far as the pathological satisfaction is concerned, we have been able to manage it. So our operative time has been around 200 minutes for all these cases. That's the average that we have taken, and blood loss and hospital stay has been acceptable. So this is my attempt into getting into surface accessible organ surgeries using minimal access, and this is a list of surgeries which I have been performing, and in due time I think we'll see the results how it matures. Thank you.
So congratulations, Sandeep. You are going beyond what we expected in robotic surgery into head neck. 2009, people said you can't use robot into head neck. Now you are going to the area where we are not expecting that you can do head neck in these areas. And I think this axis is going to complete everything in head neck, except toes. You do thyroid, you do neck. Everything can be covered by this. And even in the next, maybe you are doing a free flap and everything inside can be done with this.
Yes.
So now we are going into, which was a morbid surgery, now we are going into a very, very less morbid surgery nowadays. So congratulations for this.
Thank you.
So my name is Manu Sancheti. I'm from Emory University in Atlanta. I thank the Vattikuti Foundation for allowing me to come here. Just sort of full circle, I'm from Rajasthan, and my dad actually went to SMS Medical College here in Jaipur with Dr. Bhandari. They were classmates together, so coming full circle. So I have a couple talks. This one is about robotic bronchoscopic fiducial placement for early stage lung cancer, followed by surgery. And so I'll go quickly through the first slides to get to the video. So lung cancer obviously is a very wide incidence of lung cancer throughout the world, and fortunately, at least in the U.S., we're able to find cancers much smaller due to screening. So the difficulty is how do we diagnose these and how do we treat these without taking too much lung. There's also the advent of endoluminal robotics, which has allowed us to diagnose lung cancers early, and there's potential for treatment in the future. So what we have is this is just one case presentation of using all the technology together. So it's a 75-year-old female, lifelong smoker. She was getting surveillance because she's had a Whipple in the past, and she had a ground glass lesion in her right upper lobe, which has increased in size. We discussed it in a multidisciplinary tumor board, and the decision was made to proceed to fiducial placement or resection due to the high incidence of lipidic adenocarcinoma in these kind of lesions. And so I'll go straight. In this video, you'll sort of see the operating room setup that we have here. The bottom left, that video shows our cone beam CT that we use intraoperatively. That's on a mannequin. And then the top left is our endoscopy suite, also with a CO spin cone beam CT. On the right is our ION robotic bronchoscopic platform. So I'll go to the video. And so this is the ION bronchoscopy. And so what essentially happens is prior to the procedure, myself or our pulmonologist who does most of these will upload the CT scan into the software, and the software will provide almost a GPS in order to identify and get to the nodule. And so you essentially, you see the bottom left is the GPS, the right side is the live view, and then the top is the map. And so you just follow the blue line, and if you follow the blue line, you'll end up to the green mass, and that is represents the site of the mass and where you need to take a biopsy, or in this case, place the fiducial. It's confirmed with the map on the top as well, and you can see all the measurements that are provided. We then do a cone beam CT scan, and on table, and the cone beam CT scan, we'll see in just a second, ensures that the catheter is directly going into the tumor or right adjacent to the tumor. And so that again confirms placement. Once that's done, we place a fiducial marker. This fiducial marker is a Cook coil, and it's infused with ICG on the back table. And so infused with either 0.5 or 1 milligram of ICG at the beginning of the procedure, and we let it sit and soak. And then again, right before we deploy it, we infuse more ICG. And so you can see that it's sitting pretty well into the lesion in question. The other marks up there is the pleural border, so you can see in the purple in the top pictures the pleural border piece, so you can see how peripheral we can get with these. So 1 week later, I take this patient to the operating room, standard robotic bronchoscopic intrathoracic ports. You see that it's very clearly visible on Firefly, both the sensitive mode and the standard mode, but in white light, you're not able to visualize the lesion. And so we perform a sublobar resection for this pure ground glass, likely lipidic adenocarcinoma. Sublobar resection is appropriate, and we do a full lymph node dissection as well, which I don't show in this video, but we'll do that right after. Using the robotic Sureform 45 stapler. And so once we're finished with this, this goes in an endo-catch bag and proceeds on. And then finally, the pathology shows that, well, that one is over. Pathology showed that this was a lipidic adenocarcinoma and negative lymph nodes. And so in the end, what this video and presentation shows a combination of multiple robotic technologies that can provide a lot of benefits to the patient, especially those that have potentially early stage lung cancers. Should I just go to the next one? Yeah. So I'll go to the next one, and we can have questions for both, I guess. Come back. Okay. So my next one is robotic Ivory-Lewis esophagectomy with a totally robotic intrathoracic anastomosis. And so esophagectomy as a whole, you know the open procedures, the various ones that are used. I think that is playing on its own. It might be playing on its own. No, it's okay. I'll see if we can get it. I can keep up. So we know the potential benefits of minimally invasive surgery, especially in esophagectomy, because we're in two body cavities and the esophagus lies tightly in the mediastinum. I've noticed with minimally invasive options with esophagectomies, patients obviously feel better and they're able to tolerate a diet earlier. That obviously allows significant nutrition. We've talked at length about the benefits of robotic surgery in thoracic surgery and in all surgery. And so we'll get to the procedure. Minimally invasive esophagectomy, this is a 10-year-old study, so you can imagine that bottom graph is continuing to rise as time is going on. It's been minimally invasive esophagectomy has been done for quite some time, but the robotic platform has allowed it to move forward significantly. So in terms of how I do this, and I'm only going to show the intrathoracic portion, but historically, minimally invasive esophagectomy, especially laparoscopic and VATS, has been done with the EEA stapler. I perform the procedure totally intracorporeally with a linear stapler and then a hand-sewn anterior hood. It prevents us requiring to exteriorize the conduit and perform the gastric conduit that way. And so these are incisions. And so just so you know, prior to making this obviously we've made the conduit in the abdomen in standard fashion, and we leave the conduit attached slightly to the esophagus. So we're able to pull the conduit up with the specimen side of the esophagus. So we're not resuturing the conduit back onto the esophagus as is often done. Then we finish the conduit in the chest using the robotic staplers, and then essentially cut off the proximal esophagus in order to provide a good, healthy proximal esophagus for the anastomosis. We place a retraction suture. I use ICG to find the optimum site for the anastomosis, and then make a gastrotomy. we just do a holding suture right here at the 6 o'clock position. And then we'll proceed with the stapled anastomosis. It's a side-to-side functional end-to-end. And then once that is done, it's a approximately 35-40 millimeter anastomosis. I place these two retraction sutures in the corners. I do this for most anastomosis in the chest, sleeve resection, sleeve lobectomies, double sleeves, bronchoplasty, etc. I'll do these because it holds the anastomosis up in the air for me, as opposed to having it down below into the posterior mediastinum where it's difficult to find. So it holds it up in the air, and then I always place two interrupted corner sutures because your highest area of leak is in the corners, and so I always place two interrupted silk sutures there on either side. The remainder of the anastomosis, which you'll see shortly, after you pass the nasogastric tube, or the anesthesiologist pass the nasogastric tube, is done with a barb suture. I use Stratafix or V-Lock depending on the situation. I personally do a two-layer. I like to have the mucosa everted out. So by doing a two-layer and doing somewhat of a backhand suture, it allows the mucosa to evert up. And then I follow that with a running V-Lock suture or Stratafix suture over the top to finish the anastomosis. And so pretty straightforward anastomosis. And then at the end, you can place interrupted sutures as you see fit to make sure that the anastomosis is well sealed. So usually with these we use a 6-inch V-Lock suture, sometimes a 9-inch depending on the situation. At the end of it, my time is about to run up, but at the end of the anastomosis, what we do is we'll irrigate and then submerge the anastomosis in saline or water, whatever the case may be, and then I'll have the anesthesiologist blow usually about 120 cc's of air into the esophagus and ensure there's no leak of air for that. And so this has turned out to be the most consistent way that we've done a totally intracorporeal, totally portal-based anastomosis. There's no use for an access incision and use for the assistant to pass extra devices. Our leak rate on this is less than 3%, so overall quite good for esophageal anastomosis. And so I'll move on just to finish up. And so like I said, it's a safe, efficient, reproducible method. It mimics an open anastomosis, so if you do open Ivor Lewis's, it's very similar to that. And the robotic platform allows you to be consistent that way. All right, thank you very much.
Yeah. Have you tried prone or semi-prone, or you have found you didn't do any, just do the right lateral?
Yeah, I just do right lateral because I originally copied the way we did it open. So it's right lateral, and then we slightly tilt anteriorly, so the lung falls away, and you can get into posterior mediastinum.
And you create the conduit inside the thorax.
So the conduit is mostly created in the abdomen, except for maybe about 1 or 2 centimeters we leave attached.
You were just telling I do in thorax.
So this was when we finished the conduit in the thorax. So there's about this much still attached, and then we just staple it off, because that allows us to pull it into the chest.
It's a nice video. Thank you.
Thank you.
It's very difficult to make the conduit in thorax. You can't make that.
Yes, it's very hard to make because the staplers won't bend. Yeah. So historically what we've seen with MIEs, people would make the conduit in the belly and then resuture it to the esophagus and pull it up. So I'm just skipping the resuturing part. Oh, sorry.
So, yeah, it's fine.
A great video, Manu. you still have an access incision to remove the specimen from the chest, correct? You remove the specimen through the chest.
Mm-hmm. Yeah, but it's sort of like taking out a lobe, you know? I mean, you have an access incision, but it's probably about 2 centimeters, or, unless they have a giant tumor or something like that. Yeah.
So regarding Manu, I go with the segmentectomy. So very rarely we get small tumors in India.
Yeah.
And if you get small tumors, you always are biased either to the SBRT or we then go for lobectomies. But if you have a thing like this, you have an iron bronchoscope for this, you can localize the tumor.
Yeah.
That is the best approach to for these smaller tumors.
Yeah, and that's what, I mean, fortunately in the States, we tend to find smaller cancers now with lung cancer screening and such. And so, you know, big discussion is how to identify those tumors with no tactile feedback, no visual cues, and this provides a benefit. Our team recently studied that way of doing things, and the average tumor size in mostly ground glass was about 1.4 centimeters, 14 millimeters, and the average time to resection was about 13 days after the fiducial was placed. So even after the fiducial was placed, about 13 days later, the ICG still lights up on Firefly. So you can time it pretty well. There is also the opportunity of doing it all in the same anesthesia in the operating room.
I would like to thank the Vattikuti Foundation for giving me the opportunity to present on modified tracheobronchoplasty using a robotic assisted approach. I'm from the Mayo Clinic in Jacksonville, Florida. So I have no disclosures. So for those of you who are not familiar with what's going on here, the tracheobronchomalacia is a life-debilitating condition. It's manifested by severe cough and shortness of breath where there's collapse of the trachea. And this is estimated to affect approximately 10% of the population, so many more than we are truly aware of. And the traditional treatment for this is called tracheobronchoplasty. It is done through an open approach using a thoracotomy, and typically use 3 long strips of mesh. And totally you place about 100 interrupted sutures. And for this, it's a very laborious procedure. And the way it is done is usually you have 25 rows of 4 sutures in each row. And you place 4 of these sutures first, pre-place them, and then tie them all at the end. So robotic tracheobronchoplasty is obviously an extension of the open procedure. And what has happened is everybody's just tried to copy the open procedure. Unfortunately, this is extremely cumbersome, as you can see the picture here. It is a shambles of sutures. There are so many sutures. In some cases, they have documented more than 10 hours to do this, especially when you're starting off this procedure. And it is a hard procedure to teach. So I did a couple of these, and I thought to myself, what on earth am I doing? And why am I torturing myself and my team? So I decided to modify the whole thing. So instead of using 3 long strips, I cut these into smaller pieces and can reinforce them with felt. And so we use Prolene mesh and soft felt. And instead of interrupted sutures, I decided to use 3 of permanent barbed sutures in running form, as I'll show you in the video. So here you have my port placements. Typical, I use the same port placement that I use for lobectomies. And so the modified robotic tracheobronchoplasty, this is after dissection. We start at the top. Here we deflate the endotracheal cuff, which gives us a good view of the edge. Start from the right side of the tracheal cartilage and work our way to the left. And each bite is we take about 4 bites for each row. And here I'm sewing it in the partial thickness bite of the posterior tracheal membrane. And then I work my way back with the same sutures. You can see here there's only 1 suture. I'm not playing around with multiple sutures. And because these are cut into small strips, it is so easy for me to see each and every single, sorry. Oh. Let me see if I can do that. Move up a little bit. Yeah. Apologize for that. So each strip is then, each suture, as I said, takes a partial thickness of the posterior tracheal membrane. You have to take care not to snag the endotracheal cuff there. And then I work my way back. And instead of tying all the sutures at the same time, what we do is at the end of placing every row, when we run this, I use the cardia forceps or the prograsp. We use it to kind of pinch the edges of the trachea together. And as you'll see here, when I pull and tighten the suture. So that's what I'm doing there. So that takes off the tension and prevents the posterior tracheal membrane from being ripped off. Because that's the biggest fear, is that you may tear things when you're using the running suture across. And so I place about 4 or 5 of these across the trachea, as you can see here, except for the carinal one. And then this is the left main stem bronchus. And typically what happens is most surgeons will have the endotracheal tube pulled back here. I leave everything in place. I do not have the tube withdrawn. And I work with the tube in place, including the cuff on the left main stem bronchus, which is actually blown out. And we put 2 rows of the proximal trachea there, and so proximal left main stem bronchus, and interrupted sutures for the distal portion there. I still use some interrupted 4-row PDS sutures because it's so thin. And then I work my way to the right side, and this is the right main stem bronchus here, and the vagus nerve is the nerve that you see there. So work into the upper lobe there, and then also that's also another modification. I create this Y-shaped mesh. And so that is essentially the procedure, and I've simplified this to make it very easy and to be done in about 3.5, less than 4 hours overall, as we're getting better at this. And this is the finished product. And if you were to look at the bronchoscopy, the one on the left side of the screen is pre, and here's the post. You can see how wide open it is. You can see the dimpling in the back wall. So our outcomes very quickly. So we did about 68 patients from 2019 to 2024. We have done a lot more than that. Of these, 38 are open, which is done by my colleague, and 30 are robotic tracheobronchoplasties that I do. I have not converted a single. And so if you look at the results, the operative times are very similar, maybe a little bit less as we're getting better with the robotic than the open. And the differences are not too many, but the estimated blood loss is less. The chest tube duration, we have only 1 day versus 3 days for the open procedure. And as you can see, no patients were admitted to the ICU except for our first patient, because that was part of the protocol. Since then, we are not admitting any patient to the ICU who've had the robotic procedure. And redo tracheobronchoplasties, in long term, we find that about 13% of open patients have had redos, while only about 1 patient. And that was done about 3 years later. And that was an extension into the left side, not actually a redo of the main trachea. And delayed complications, 30% versus 6% for open versus robotic. And here is the final slide, the lung function. We see total lung capacity is actually lower in patients who have gone through the open procedure compared to the robotic procedure, while all the other tests, the 6-minute walk test, the other respiratory quotients are on cough, quotient are also much less for both, but the improvement is significantly better, or is better in the robotic procedure. With that, I would like to thank you again for listening. If you have any questions, I'd be happy to answer it now or take it later on if you need to know more about the procedure. Thank you.
It's an excellent video. I've seen it first time. I've never seen this. It takes 10 hours to do it.
Well, if you're learning, if you're starting it can take up to 10 hours, and because the sutures, they're very hard to manage when you have so many sutures and you don't know which is what. Some people use color-coded, but they're floating all over the place. So this has made it very easy for me to just run through it. And I think even in the best hands, it can take somewhere 5 to 6 hours, you know, even in those.
And what are the age group of the patient you operate for this?
I've operated up to 80 years old.
80 years.
80 years old, anywhere from 30. Patients who have had previous radiation for lymphoma, that's the patient with the redo one on the extended side.
Youngest one is 8.
What's that?
Youngest age is 8 years.
Youngest age for me is 30. And oldest is 80.
Excellent video.